Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 43. Pain relief. Pain in childbirth is interesting. How we perceive it. Again, I hesitated with the title of today's episode. Just using the word pain in itself feels like a judgment. The definition of pain, according to a dictionary, is physical suffering or distress. And that is true. A lot of women experience physical suffering and distress during labour. Pain. This is an important topic, not only because we need to think about how to care for women that are in pain and offer them pain relief options, but also because we use pain as a gauge for what is happening. Sometimes we use it as a judgment for the right time to be admitted to hospital for a hospital birth, or the need to transfer to a labour room from our antenatal ward. But we can overlook the most important point, that women will feel pain and express their response to pain in a huge variety of ways. To start this episode, I thought I'd go back to basics and think about what actually causes the pain of labour. And what education have I had about that in my training? I opened to start with my postgraduate textbooks. So I have one on basic science in obstetrics and gynecology that I used to study for my first postgraduate exam. Its suggestion on pain and labour pain is extremely limited. Limited essentially to the anatomy of the pudendal nerve, which I'll talk about in a moment. My 1999 standard edition postgraduate textbook, in the whole 600 pages of obstetrics and gynecology postgraduate training, there is a single paragraph on pain relief in labour, which essentially states that the wide variety of pain relief options will not be explored. I find that somewhat bizarre, that for a profession that are going to spend perhaps 50% of their week caring for women in labour, it doesn't warrant any exploration. Next, I looked at the e-learning and continuing professional development articles published by the Royal College of Obstetricians and Gynecologists. And I did find an excellent review article published in 2015. The start of this article was an excellent description about the origin of pain from different sites during labour and childbirth. In the first stage of labour, pain is transmitted via the spinal nerves of the thoracic 10th vertebra to the lumbar 1st vertebra. And the pain results from the contraction of the uterus and dilatation of the cervix. It's what we call visceral pain. So most internal organs do not have much nerve supply, but if the viscera, the internal organs, become very distended, then this triggers nerve stimulation. So the labour pain of the first stage of labour is thought to be due to visceral stimulation as the lower segment of the womb becomes dilated and the cervix starts to dilate. In contrast, the second stage pain is due to stretching of the pelvic ligaments, causing pain via the pudendal nerve that I just mentioned. The pudendal nerve runs down both sides of the pelvis, originating from the sacral second to fourth nerve roots. Compression of the pudendal nerve causes pain, and this is a sharper pain than the pain of contractions. One of the things that interests me about pain is how women respond. So each woman has the same anatomy. Her body is essentially going through the same process. Yet the way women approach pain and the way they express pain is remarkably different. This results in women using a wide variety of pain relief options or none at all. And this diversity really interests me. Since I had my own babies, I've wondered for a long time whether a labour that's progressing really well with a baby in a good position, that's going quickly, smoothly, whether the pain experienced by that woman is different from a woman who has a baby in a bad position, perhaps occipito-posterior or back-to-back, where the labour is potentially obstructed. Is that labour more painful? Having had 2 back-to-back babies myself, I know that in labour, when I thought the pain was positive and bringing me closer to my baby, I could manage the pain. But once I knew I wasn't dilating and the baby was in a back-to-back position and my labour wasn't progressing, it became more painful. So there's a large psychological component, but I also wonder anatomically whether some labours are more painful than others. Going back to my 1930s textbook of obstetrics is fascinating. It discusses pain relief options and it divides them into 3 categories. The categories are diminishing the woman's sensibility but not causing unconsciousness, loss of consciousness, or obliteration of the memory of the event but not reducing suffering at the time. I find these interesting distinctions. Initially, when I started to read it and think about loss of consciousness and the descriptions of loss of consciousness for some quite straightforward procedures, it felt like my 1930s colleagues were perhaps using a sledgehammer to crack a nut. Making a woman become unconscious, after all, is excessive. However, as I read more and looked at the tools that they were describing, morphine, chloroform, and Entonox, the modern day gas and air, there were actually some really interesting descriptions of the use of reducing the woman's conscious state to allow a very slow, controlled birth, both with instruments and without. Harking back to last week's episode about instrumental birth, in particular, there was a fascinating account of forceps for a brow presentation. The book describes very light anaesthetics, applying the forceps to exert a very slightest amount of traction. And in this manner, the woman virtually delivering herself under the guidance of the instrument. That in itself did not surprise me. However, It mentions that the process was a long one, occupying anything from 1 to 1.5 hours. That's an extraordinarily long time for an instrumental birth, and suggests a degree of patience that perhaps as modern obstetricians we overlook. It made me think about birth under anaesthetic, birth unconscious. This is extremely rare these days, to have even a caesarean birth under a general anaesthetic. We know general anaesthetics are more risky for mothers and babies. The only vaginal birth I've ever seen under a general anaesthetic during my career was by accident. We had a woman who had a baby that was distressed, and at the time the hospital I was working at was doing some work on its maternity theatre. So unusually we had to go all the way down the corridor to the main operating theatre at the other end of the hospital. We rushed down there knowing the baby was in distress. We put the woman to sleep, and as we prepared her on the operating table, we looked down and saw that the head was visible. And I performed a forceps birth under general anaesthetic. It was the weirdest birth I've ever participated in, as the woman was unconscious and ventilated, and therefore unable to push or participate in any way. And I'm not recommending this as a way to give birth, but it did mean that I was completely able to control the birth, and I do remember that she didn't have any tears or cuts as a result. Food for thought, perhaps. So in the modern era, pharmacological pain relief options are not that dissimilar to the 1930s. We offer opioids, such as oral morphine, pethidine or dimorphine injections. These do give women a degree of pain relief, but equally do cross the placenta and can have an effect on the baby. They can make a woman sleepy. They can take the woman away from the pain, but they don't necessarily have a great effect on the pain itself. Gas and air, known as Entonox, is very frequently used. It's a mixture of nitrous oxygen and oxygen in a 1-to-1 ratio. It was introduced in 1962 and is the most popular form of pain relief. It acts as a very weak anaesthetic as well as a form of pain relief. The woman has a mouthpiece she holds on a piece of tubing and breathes in and out. This can be very useful for difficult examinations. If we need a woman to relax and we know something's going to be uncomfortable, giving her gas and air, getting her to breathe it for a few deep breaths before we start can be very beneficial. If she takes sufficient amount that she starts to feel sleepy or lose consciousness, she will drop the mouthpiece and stop administering it. So it's self-regulated by the woman. Some women love it. It gives them the giggles, makes them feel a bit drunk. Some women hate it. They feel it makes them feel very spaced out, peculiar, out of control. So it's certainly not one size fits all. A local use of anaesthetic is a pudendal block. That blocks the pudendal nerve that I mentioned is compressed and stimulated in the second stage of labour. This nerve runs either side of the pelvis by the ischial spines, the bony prominences of the pelvic outlet, and an injection of local anaesthetic by these nerves using a special sort of needle called a pudendal needle can provide good pain relief that we can use to perform assisted birth in women who have not otherwise had pain relief during labour. This is a technique that obstetricians use rather than midwives or anaesthetists. Regional anaesthetic, such as epidural and spinal, were introduced in the 1960s and have become increasingly popular. These are injections into the epidural space, the membrane above the nerve endings, or directly around the nerve endings, that cause a block. It interferes with the conduction of the nerves that carry pain and temperature. But it can also have an effect on a woman's mobility. Spinal will cause temporary paralysis of her legs, and epidural will progressively if she has multiple top-ups. So although they provide excellent pain relief, they make a big difference to a woman's experience of labour, in her ability to move around, in her ability to control her bladder. So often women with an epidural or spinal need a catheter tube in their bladder. Women aren't able to be up and about, walking, squatting, in all fours, good positions for labour. Epidural is difficult. In the unit I work at, perhaps 30% of women will have an epidural, and it is a very good form of pain relief, often allowing women to rest when they've been up for hours with contractions and they're exhausted. They can change from being distressed, stressed at the end of their tether to being relaxed, smiling, calm, just from the intervention of the anaesthetist. So they can be fantastic. However, sometimes I feel they take away that confidence in a woman's body of how to birth a baby. I remember when I rotated from a hospital that had very few epidurals to one that did have epidurals, I found it very difficult doing the ward round. It almost felt like the sound of the labour ward, the feel of the labour ward was wrong. If you work on a birth centre where epidural isn't available, you will hear the noises of labouring women. When you go in the room, the woman will be entirely focused on her body, on her baby, and what is happening to her, whether she's crying out or not. If you go into a room with an epidural, I remember when I rotated to this unit that had a high level of epidural, that I was astonished to go in on the ward round and find a woman reading a magazine, chatting to her birth partners almost as if she was having a coffee date. Didn't feel like a labour ward. It had a very different feel. Labour was something that was happening within her body, but with her being oblivious to that fact. It felt very peculiar. And I wouldn't want to deny any woman good pain relief. And I did, in my labours, in the end, have an epidural myself. But it certainly wasn't something that I wanted to do. And it certainly, I don't think, enhanced my experience of labour. The happiest time for me in both of my labours, even though if you listen to my motherhood episodes, you'll know they ended in emergency caesareans. The happiest time for me was the time I spent in the birthing pool with Entonox, working with my body, enjoying that buoyancy, that mobility, and using pain relief if and when I needed it. Because let's face it, the pain of labour is a strange pain. Strange because it comes and goes. So you have very intense pain for 60 to 90 seconds and then nothing for 60 to 90 seconds and then very intense pain for 60 to 90 seconds. It's the most peculiar pain you'll ever experience. It's an incredible rhythm. A rhythm that gives the baby a break, because labour is a stress for any baby, but also gives the woman a break, gives us the capacity to manage to get through those pains, because we know after each one we'll have a little moment of respite. What about non-pharmacological methods of pain relief? I've already mentioned water, birthing pools, warm water, having a shower, having a bath. It's one of the first things we suggest women do in labour. Water can be incredibly soothing. Just as if your muscles ache, you might choose to have a bath, a warm bath. That warmth helps relax you, helps alleviate the pain. It's the same in labour. Plus the additional factor of buoyancy. You felt a little bit like a stranded beetle, a beached whale. Your body's changed beyond all recognition. It's become extremely cumbersome to move around. And then suddenly you can get in a pool and feel light as a feather, move with ease. It's fantastic. We also use birthing balls extensively at work, allowing movement, rocking, massage, aromatherapy, the touch of someone else caring for you, rubbing your back through a contraction, rocking with you, supporting you, is beneficial. That's why it's so important that women have their birthing partners, and that's also why one-to-one care from midwives is so important. It's demonstrated time and again that having support during labour, and particularly support of someone you know, reduces the amount of pain relief a woman asks for. Another commonly used method is a TENS machine. That stands for transcutaneous electrical nerve stimulation. This sounds totally bizarre. Essentially, low voltage electrical impulses are applied to the lower back. The vertebra levels T10 to S2. Remember, that's where I said the spinal nerves are taking the pain from the pain receptors in the first stage of labour. This is where the nerve pathways from the womb, vagina and perineum enter the spinal cord. Women can adjust the frequency and intensity of the electrical impulses delivered. And we don't totally understand the mechanism of action, but it's thought that these impulses block the transmission of the pain impulses within the spinal cord. A lot of women use this method in the early stages of labour. They can turn it on when they have a contraction and turn it off when they don't. I've put in the programme notes some good links to information about different forms of pain relief. And I don't want this episode to become a comprehensive list of options. What I'm more trying to get you to think about is pain in itself and how women respond to it. People have very different expressions of pain, and I think we can struggle to recognise this in our day-to-day work. So for today's zesty bit, the little nugget that I want you to take away from today's episode, I'm going to talk a little bit about pain and assessment of someone else's pain. I think we make the mistake of making judgments about someone's pain from their behaviour. I've had women labour silently, be left on their own, be told they're not in labour, and then they're fearful the next time that they will not be taken seriously. They will not be believed. I've also had women who have experienced enormous amounts of pain be told they're making a fuss, they're not in labour, stay home, or no, we're not going to examine you, you're not ready yet. So we can make the mistake of using pain relief as a gauge for our other support and treatment of women. I commonly hear when women are on the antenatal ward having an induction and they're waiting to come to labour ward, the question asked, do they need pain relief? If they don't need pain relief, often they will be left on the antenatal ward. And this can be a mistake. Not requiring pain relief does not mean a woman is not in labour. It means she is coping with that pain in a different way to perhaps what we're expecting her to do. Just as with everything else in maternity care, it's very important to individualise things. And this is exemplified by a couple of situations I've come across in my maternity experience whose shoes work. I'm going to read you a couple of scenarios. First, a poem written by Jill Phillips. You look fine to me. I say, I'm in pain, but my words are in vain. Words count for nothing, it seems. They deal in screams. At each contraction, they watch my reaction. I say, I am in pain, again and again. It's a fact, but it seems I must act. Grimace, pull a face. It is not who I am. Autism. It is written in my notes. But what does it mean? Unless I am seen to make a scene, I'm officially in little pain. And it must be true. It's written in my notes. That's an example of an autistic woman who is expressing pain in a different way. But there are many other examples. And I'm going to read one more now. Wait. I wish I'd gone to hospital sooner when I was in labour, but on the phone they kept telling me to stay at home a bit longer as I wasn't in enough pain. I was lucky not to give birth in the hospital car park. Why do women have very different ways of coping with the pain of labour? Not only do we have different personalities and different ways of coping with situations, there are also cultural manifestations. And preparing for today's episode, I read a little bit about that. Different cultures see the expression of pain differently. Some see screaming, emotional expression as the norm. A paper I read suggested that this was more common in those perhaps from Mediterranean backgrounds. Some cultures see expression of pain as a weakness. And I came across this in some Asian and African countries, that these women become quite stoical, turn the pain inwards, see lack of expression of pain as a strength. Don't cry out. Don't express themselves, as this is viewed negatively. Expression of labour pain can also be mixed with religious beliefs. I've seen articles that have looked at the comparative difference of women who see the pain as spiritual and a trial by God, and how God wants them to respond to the pain. So we need to be cautious. We need to listen to a woman, not judge her by her behaviour. Be aware of different cultural responses to pain, as well as different awareness of different personalities. So expression of pain is a very complex issue. We need to listen to a woman, look at a woman, talk to a woman, and understand what is the norm for her, whether that's a cultural norm, a religious norm, or just her personality or the way she is made. Understanding how a woman normally responds to pain will help us understand how she will respond to the pain of labour, and therefore how best to care for her, regardless of how she seems to us. If you're a pregnant woman listening to this podcast, I hope this has helped you think about your options and how you might respond to the pain of labour. I've enclosed lots of information in the programme notes so you can do some reading if you wish. But also think about helping your caregivers understand how you might need to be supported and how you might express how you're getting along. I do hope you've enjoyed listening to this episode of theobspod. Feel free to contact me on Twitter at FWmaternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.